in the beginning. So really, if you take a look at this, it's always a personal aspect of medicine. So this goes before I was born. On the left is my grandfather. I never knew him because he died of a stroke in his mid 60s. My father is on the right. And when I was a junior in high school, he came into Methodist with some atypical chest pain, had a cardiac arrest. Luckily, was resuscitated and ended up later on having bypass surgery and lived to the age of 80. But in the middle is my aunt, and she's actually the one who died at the youngest age. She was 60, and when she had her first symptoms, it was unfortunately the last day of her life. She lived on a ranch in Arizona, and as is common, a lot of times women, there's not the same awareness of having that it was a heart attack, and she unfortunately died that day. So there's a lot of personal interest in the prevention of cardiovascular disease. Now, here is my mother's family, and she had three brothers. So the first question is, in terms of genetics, what did I get from my mother's side of the family? Uh, so if we go backwards, you can pretty obvious on one of the similarities here. But if you look at my family tree, it ends up is that my grandmother also had a stroke. And so on my mother's side, her brothers all became diabetic. One had a severe stroke. My father's side, they basically all had heart disease. His sister, the other one died young. And unfortunately, my older brother died of an MI at age 68. So genetics plays a very important role in regards to uh, where our likelihoods for developing disease. Probably shaped a big part in terms of when I was a Baylor medical student. I did a rotation with someone named Liston Beasley, who was a cardiologist at Methodist. My dad was a surgeon, and I thought, well, this is a great field. You get to do procedures, and there's medical. And I decided I wanted to go into cardiology. I went to UT Southwestern, and it was really pretty phenomenal. It took me a while. It's exciting, and people came with MIs. But when I started thinking about what did we actually do for them, these were our orders for an acute MI. You gave them oxygen, you gave them some pain relief with morphine, nitroglycerin, and then you watched them. I mean, it was just, and then, if they would have an arrhythmia and VTAC or VFib, you'd shock them. We questioned was prophylactic lidocaine or not. It was really, we didn't do much. It was just natural history. It was when I was a fellow, I think Neil was one of the people who started Timmy One. And Neil was a fellow in about, what was that, 1960? I'm just kidding. Neil's not here uh, and then in terms of prevention, it was even worse. Well, I know it could be worse than watching people have MIs and not doing anything. High cholesterol was 300, systolic blood pressure. So if you were 75, you were hypertensive if your systolic was over 175. Anything under that, we were okay with it. And let's face it, one of the reasons I didn't go into medicine, people would come into the clinic and they would dump a big bag, diabetics with a big bag of medications. There'd be no chart. They always had hypertension, hyperlipidemia, diabetes, bad vascular disease. And if their glucose was under 300, we were all okay with that. So it was really terrible. Now, one of the things that came up is the frustration of watching these diabetic patients come in and they'd lose a toe, and then they'd lose a foot, and then they'd have an MI, and they'd have a stroke. And I realized we were just watching the natural history of atherosclerosis. We really weren't intervening in it, and we didn't really understand it. And so somehow I went from thinking cardiology was a really great field because you got to do a lot of procedures, and you got to practice some medicine, and then I got involved with lipids and atherosclerosis, and now I end up working a lot on diabetes. So anyway, life can't always plan out the way it's going to go. So we've had a big evolution since that time. It was really very primitive in terms of what we're trying to do for people who had acute MIs and atherosclerosis. And we've gone through successive guidelines, and they first talked about LDL, and we've had some updates. And our most recent guidelines have really come into the importance of risk assessment, determining what you do with both lipids and blood pressure. And although my focus has been on lipids, I will tell you we're doing some of our work right now in blood pressure. If you look at long-term cardiovascular health, is extraordinarily important. We're going back right now, we're looking at people in the ERIC study who are in their 70s and 80s, and there's lots of people who don't have any cardiovascular disease. They have normal echoes. They have normal biomarkers for NT-proBNP, troponins, and everything else. And guess what the average systolic is? 110 when they're 55 years old. That's a really healthy blood pressure. And most people in family practice feel like, well, as long as you're under 140, everything's fine. It's not all fine. So it's just like LDL. The optimal blood pressure and optimal LDL, people who have really good numbers do really well. So there's more about risk stratification, quantitative assessment, pool-Court equation, risk enhancers, and finally, there's in the guidelines, cardiac CT for risk assessment. Okay, so we'll start off with a case to illustrate a couple of key points when we talk about risk assessment. 71-year-old white woman, she presents for routine annual physical exam, history of arthritis. She says her hypertension was borderline. She has no history of diabetes, cardiovascular disease, cancer, chronic inflammatory conditions, non-smoker, family histories for hypertension, diabetes. Her mother died of 80 of heart failure. Her physical exam, she's 148/80. She's overweight. She's taking ibuprofen. This is her lipid profile, good HDL. Triglycerides a little elevated. LDL borderline 116. Elevated CRP. She's overweight and has arthritis. Glucose is 115. So her Framingham risk score is 5% for her 10-year risk. The Reynolds risk score, if you were to count CRP in there, is 9%. The pool-Court equation is 13.7%. So you got three different numbers in here for the same patient, different risk scores. So there's lots of controversies, and people are saying, well, the pool-Court equation overestimated risk. So which risk equation should you use predict? I think people are missing the major point. The major point actually is that what health conditions should you include for risk prevention? The other one ends up being is how do we communicate that risk really in terms of being beneficial for our patients? So Framingham, the old one, was just fatal and non-fatal MI. Reynolds included stroke, so did the pool-Court equation. Revascularization angina, not included. Heart failure, not included. Developing diabetes, not included. So think about it. You see somebody and they want to know what their risk is, and you tell them a risk about, if you take a look at this person, she's more likely to have revascularization than she is an event, but the other one is heart failure. So you're giving them actually less than half of the events they're going to have for a short period of time. Now, how can that motivate anybody? I mean, the way we do this, if you think about what we're trying to do is change people's lifestyle and work on adherence, we don't give them all the information. We underestimate, no matter how you do it, what's going to happen. So I think it doesn't make much sense. And we can do a lot better than that, I think. So personalized medicine, we start off with risk assessment, giving the important information. Then we have therapies tailored to the risk. And finally, joint decision-making, and I would say we have a long ways to go in the term of how do we present the information to really improve adherence to both lifestyle and medical therapies. I think the way we do it right now, it doesn't really make sense, and I think most of the people who are talking about joint decision-making don't see patients because we'll go into some of the other things if there's questions about that. But showing a chart that if you take a medicine for 5 years, you'll have three figures, and 1 person out of 100 will have a benefit. How could that motivate anybody to take a medication? I mean, the way it's presented, if you got it presented to you the benefits of taking a seatbelt by statistics, that 1 in 10,000 people who wear this for 5 years might have a benefit, who would wear a seatbelt? None of you would with it. I mean, so the way that one presents information, life insurance, do you try to sell life insurance to someone and present information the way we try to sell lifestyle and adherence? No one would buy it. We don't do it in a way that really is motivational to individuals. Okay, so how do we do risk assessment? Well, traditional risk factors, there's blood tests available, some advanced lipid testing, LPAs, one that's becoming more and more important, HSCRP, markers of subclinical injury that we'll talk about a bit. Imaging, I'm not going to talk about because this group knows a lot about imaging, so I don't need to talk to you about imaging. And we go to calcium scores. Calcium scores made it into the guidelines last year. John, when did we start doing EBCT here? 25, 26, 27 years ago?
20 years ago at least.
Well, I know it's more than that because I got one 24 years ago. So they were for free. I think we got one for free because they were doing it for people. But and then I found out I was 39. I had calcium. Pretty important. There you go. That was the family history there. I was thinking, did I really inherit that or not? Yes, I did. So very useful tools, and then genetic variants. We'll talk more about that. So when you're talking about risk, it's important to consider age. When you're looking at people who are now at this point in my life, I say young is less than 50. So basically, what's the major event? Atherosclerotic events. You're talking about over the next few decades, 10, 20, 25, 30 years, are they going to have an event? Traditional risk factors work very well. ROCs are 0.82, 0.83, like for example in the ERIC study. When you get into older people, which is where most of the events are occurring, heart failure is more common than ASCVD. Why are we giving a 10-year risk to somebody who's 78 years old? Wouldn't be 3 to 5 years be more relevant for that individual? And the other problem is the traditional risk factors. Cholesterol is a very poor predictor when you get old, LDL. So markers of injury are rare when you're young, NT-proBNP, troponin I, troponin T. When you're 45 years old, very few people have elevated levels. They're very common when you're 80 years old. So let me just go over some of the data in the elderly from the ERIC that was we published last year. NFC looked at this. So this was the people on the 5th visit. They're 75 years old on average. We've been the core laboratory for the ERIC study. It's up on the 7th floor of this hospital for the biomarker labs. We've got a few million samples there, 16,000 people who've been followed since 1987. They're now finishing the 7th visit, and the 8th visit's going to be starting. This was the 5th visit. They were 75 years old. At this time, we take a look at the most common event with 3.5 years of follow-up, admission for heart failure hospitalization. It was not an MI or stroke for it. So really, having a risk equation that doesn't tell anyone about your risk for heart failure hospitalization, that's kind of ridiculous, isn't it? You don't even mention the most likely cardiovascular event they're going to have for these people. So we really should be looking at global CVD, in particularly as people get older. And if you look at that, the only one that we commonly get is HSCRP for risk prediction. It's the weakest predictor. If you look at NT-proBNP or troponin T, much more powerful predictors. And it's very interesting. We used NT-proBNP to diagnose in the ER. ER docs all get it. But cardiologists rarely will order an NT-proBNP for risk classification, despite the fact that it is way better than CRP. And unlike coronary calcium is great for atherosclerotic events. It does not predict incident heart failure well. This actually is additive to echo. So actually, this is a very good screening test. If it's abnormal, what's next? An echo is next. And as we all know, echoes are great, right, Bill? I mean, for you could get an MRI, Deepon. I got to admit, that might be if you wanted to really get the definitive test on these things. So we look at risk prediction, and this is the pull-cord equation does poorly. This is the issue that comes up when you get to this age. This is also putting in heart failure. You throw in some biomarkers, now you have a pretty good ROC. And you can actually use just the biomarkers without the clinical variables. So this would be like the way we get an EGFR. Just using the blood test, age, gender, and race, you end up with a pretty good predictive value here that could be reported out automatically, which would then trigger an imaging test, right, Bill? Or Deepan? Okay, now, we went backwards, and what ends up happening, if you look at age over 80, here was the PCE doing very poorly. You go to less than 80, it's doing a little bit better. If you were to go back to earlier visits, around age 50, it's a 0.82. So traditional risk factors predict very well when you're younger. They don't do as well when you're older, and most likely because when you're older, looking at an event happening in the next 3 to 5 years, what's more important? The presence of disease, right? That's what's important in terms of that. And the other one that does come up, we're looking at this in the ERIC study now, and finishing up, they're getting calcium scores, and a lot of people, even at this age, have 0 or very low calcium scores. So the other issue that comes up is you can grade a number of people. We just published this in Circulation that troponin I, a different biomarker than troponin T, we use them either one for a diagnosis of acute MI. It turns out the correlation in the primary prevention arena is actually pretty low, and they were additive. Different genes, different regulation of the genes, some differences in the assays, but they actually were additive in the value for predicting cardiovascular events. Okay, so I think that personally, NT-proBNP has been ready for prime time. I don't know why we don't use it. It's better than HSCRP, far and away, for both atherosclerotic events and heart failure. And the high-sensitive troponins are also very good in the population that is already thought to be at some increase in risk for heart failure, which is going to be a lot driven by age and hypertension. What about the other things? Proteomics, metabolomics. So these are some things that were ongoing with the ERIC study. Genetics. Yeah, I did a postdoc in genetics many years ago. After my cardiology fellowship, went to work in a laboratory with Art Bodette. Fortunate that I worked under this postdoc in there that her name was Huda Zogby. So I got some very good training, but that was a long time ago. I didn't order genetic tests until 2 years ago because they were just too expensive. And now we're starting to fairly routinely get these. More recently, we've been doing them because of a study we're doing at Baylor and another study I was doing with another company with it. And then obviously imaging has radically changed in terms of coronary calcium scores, CIMT plus plaque, as is done here, not in other places where you just get a CIMT alone with it. But the problem ends up is that there's no quantitation. Fuster's work has been CIMT and femorals with 3D with quantitation of plaque for young people. I don't know why we don't do that more. And obviously CAC plus CTA with low radiation, and then MRI. There's a lot going on, and that's going to continue to progress. That part I'm not going to cover here. Metabolomics, so we just published this last month out of ERIC. This was using so it's a chromatography mass spec with metabolome. It's a commercial company, and it's looking at incident events. In general, with metabolomics, you don't find anything with a very huge hazards ratio. It's more for pathways, and there's amino acids, branched chain amino acids were bad. There were some things that looked promising with fatty acids in terms of beneficial. So this has been done a lot. It's, I think, more understanding pathways and disease paths. I haven't seen much out of metabolomics that's really going to improve diagnostics in terms of risk factors. Proteomics, there's multiple methodologies. On the top here is what we have been doing for a long time now, I think almost 20 years upstairs. We have 2 multiplex machines with Luminex platforms, so it's microspheres that are coated, lasers. You can run many assays in small sample volumes. These are 2 things that we've just started working with. So one of them is aptamer arrays. That's with a company called SomaLogics. And they have 5,000 proteins that are measured at one time. You get a relative concentration. And the other one is proximity extension assay, and this is a PCR methodology There's a company called Olink, and we've been collaborating we've gotten some studies with them that are ongoing too, and then you can do some validation with mass spec afterwards. So in regards to this, the aptamers, we have finished this on I mentioned visit 5, so we have all the data back from that are in the process of analysis. They have been shipped all the samples from visit 3, and they'll also have visit 2. So we will have this on multiple visits with 5,000 proteins. So for those of you who are interested in a specific protein of interest, we'd be happy to collaborate on these things. Now, we've also been working with the Homage in Framingham with a smaller panel of only 252 proteins. And there's some very interesting data that's come out of this already, which hasn't been published, but looks quite promising. Now, these both do not give you an actual concentration, so very frequently I think there'll be a lot more work afterwards in terms of coming up with a clinical assay. I personally think clinicians are always going to want to know an absolute level, and then you can look at the changes over time rather than a relative concentration. In terms of genetics, we have started a demonstration project with the Genome Center where we're using 158 genes are being sequenced that are related to cardiovascular disease, polygenic risk score, and then also some pharmacogenomics. This is what the report looks like here. So it's 158 genes. It's in the area of lipids, atherosclerosis, coronary disease, aortopathies, arrhythmias, cardiomyopathies. We have a polygenic risk score. There's some pharmacogenomic markers, which probably is still, I think, a pretty weak area at this time. And then there'll be a report that's coming back where we've done about 200 people thus far, and we'll do 1,000 here, and within the Common Spirit Network, around 5,000 people for this. I was surprised. I got a phone call from somebody in Phoenix, Roger Bees. Remember Roger Bees? He said, hey, we're excited about starting this thing. It's just, and by the way, Bob Roberts joined me. So so that was an interesting thing. For those of you who didn't know, Bob Roberts had been pushing this many years ago at Baylor with it. So life kind of goes around in circles. So polygenic risk scores. This has gotten to be kind of a very controversial, I would say almost an emotional area from looking at things on Twitter about this and having done a debate at the EPI meeting. So monogenic factor, familial hypercholesterolemia is a great example. So if you take a look in the population, it's 1 in 250. Premature MIs was 1.7%. So you have an increased risk, lifelong, it should be identified. It's missed a lot. But basically, if you do this, you would catch 1.7% of the people with premature MIs, okay? So, which is useful, but what about the other 98% with premature MIs? So could we, if we're gonna do genetic testing routinely, could we get more out of it? So this was looking at a polygenic risk score, and this has been a lot of work that's been done by Mitker and Sekithirasan and his colleagues at the Broad and MGH. And so what they did, they showed that if you used a polygenic risk score, many genes here, that you would actually identify 17% of the people who are at increased risk with premature MIs. You would have. So you'd get more people with this by doing this approach. Now, what one would argue, people say is, well, why not just do a coronary calcium score or do some other type of imaging test with it? There's a lot of people who say you haven't had the same kind of rigor of testing with this methodology yet. And that's true. This is new technology. We don't have all the data on it. Of course, we didn't have the data on coronary calcium scores 25 years ago when we started doing them here also. So why would we're testing this in the clinic right now for this, trying to get more information. And part of it is, if we look at what's already happening, companies like 23andMe, this is the timeline for direct-to-consumer testing, but notice in 2017, the FDA said, listen, it's okay for companies to give people genetic tests for health risk prediction. That's been approved And so it's a wonderful thing to have these debates in academic circles about should you do genetic testing or not. But it's useful also to see what's happening in the real world. And in the real world, this is the graph for what's happened with consumer genetic companies in the millions. In other words, we can argue all we want, but people are basically, here's the 12 million people have done this, and most of it in the last 2 years. So it's happening a lot, and this is a little bit of I see the arguments of, well, should we be doing all this genetic testing? Do we really need this? Is this going to be useful? What's the point of all this stuff? So it's a little bit here, this guy, cartoon, we don't really need these. What is this stupid thing you got there? This round thing that's going around. We don't think we need that here. So I think the issue ends up is the NIH actually put a statement out that there needs to be some evidence in regards to how one uses genetic testing, and in fact, how do you even communicate the results to the physician, to the patient? We have a small grant as part of this study to try to understand the communication aspects of it and get some ideas of really how can we make this more useful. It's going to happen. So here's the issue with why genetic testing. What's the biggest problem with prevention? The biggest problem with prevention is that we do too little, too late. That's the biggest problem with prevention. And, this is the example of here, somebody comes in and they've had a big MI and they end up getting a, urgent PCI, they get an Impala, there's all the drama with that. Or even worse is it's too late, they've really had a huge amount of damage, they get an LVAD and then they get a transplant. So, and that's heroic, that's better than this little bucket of water they're throwing on there. But that's the firemen running up and running into the building and trying to save somebody and everything else. And it's an incredibly valuable service for that person who's stuck in the building. However, smoke alarms and planning and a lot of really boring stuff, how you don't leave things on the stove, you have these smoke alarms, the way buildings are planned and engineers, that saves far more lives. Okay? So that's been the difficulties in prevention. We're kind of over in here. This is the prevention world, like a smoke alarm sitting up in the thing. That the only time you notice it is when the battery starts to beep. And then here's the rest of cardiology over here, with it. But even though we're boring, it's important with it. And in fact, the biggest problem is people don't pay attention to things until, unfortunately, too late. My aunt would be the classic example of this. Her first symptoms were the last day she was alive. And what ends up happening is we don't convey risk in a manner that motivates people, which is also one of the benefits of an imaging sometimes, because it's a picture with it. So what you could do, I think, is that this is where genetics comes in. Genetics captures risk from when you're born. And so if you were going to do universal screening for FH, which has been proposed by the British, and they've shown it could be cost effective, you should also add LPA variants, which we have on our panel, a polygenic risk score, but I think it should include also not just coronary heart disease, it should include diabetes and obesity, because that's also very strongly hereditary. And the purpose of this would to begin lifestyle interventions in childhood with a family approach, get the adults and the children. And that's a little bit like what Fuster has been doing, is you work from the family side, so you're targeting both the parents and the children and the two together. And then the therapies are inexpensive. It's lifestyle, and then very inexpensive statins and blood pressure medications earlier in life. You might have seen the headline. There was a story about, young people having MIs and dying, but, we have a lot more, and also younger diabetics having complications earlier. Well, the problem is if you get diabetes when you're 18, 20 years after you've had diabetes, you get the vascular complications, you're 38. And that's what we're seeing now. We're seeing a lot of people who are in their late 30s and 40s, they've had diabetes for 20 years, and we watched it. Oh, well, should we treat their lipids? Should we treat their blood pressure? I'm not sure. Well, let's treat their heart attack. So I think we need to do a little bit better in regards to this. So this is something we've talked about with Vijay Nambi, my colleague, global risk assessment, because really there's a lot of the shared factors in here in terms of lifestyle, obesity, diet. I think you can add genetics in here, also to imaging, biomarkers. But you can look at ASCVD versus heart failure. There's two different types of disease. There's a disease, they can be related, but sometimes this is a myocardial problem, and the therapies may be different here, particularly, if, for example, if you have diabetes. This may be an SGLT2 inhibitor. This might end up being GLP-1 agonist over here. So I think there's different approaches depending upon what is the risk. Okay, now quickly I'll switch to treatment. So I was interested in atherosclerosis because it's, we weren't quite as tuned into things like HFpEF. I used to think that, well, the reason everyone got heart failure was because they had an MI. Obviously, that's not the case, but when I was earlier in the day, so I thought if you could just solve atherosclerosis, you'd kind of solve everything. This was our model, LDL going in the arterial wall and causing inflammation. And so I was doing this postdoc, and I worked with Huda. She was doing a project on spinocerebellar ataxia. And then I switched over because there was a project on ICAM-1. And I put a grant in on ICAM-1, it's intracellular adhesion molecule -1, came back, and this was the review. Why is a cardiology fellow working in a genetics lab studying ICAM-1 has no proven role in cardiovascular disease? It's like, I don't get it. I don't even know. Did this guy get lost or something? I mean, what's he doing over here working with a pediatric geneticist whose main thing was cystic fibrosis on ICAM-1? There were all of 6 papers published. Now, there are a few more papers now. 26,000 papers have been published as of January this year. And everybody knows now that clearly vascular inflammation is an important part, and it's complex biology here. I started off working in the lab, doing all basic research. Turns out by the time I started that project, I got the grant eventually got the K award, but by the time I started the project, someone else had already cloned ICAM-1. So I started working on the ligands for ICAM-1, which were the CD11 integrants. We knocked out the 4 alpha subunits and published a bunch of papers on this and had rolls of. It took about a decade plus to get to atherosclerosis because atherosclerosis are chronic experiments that were too expensive. When you're young getting started, you have to do short-term experiments because you got to publish results to get the grants with it. So it really took about 20 years to be able to do this, where we looked at the impact of the C11C knockouts in the ApoE mouse model, and we saw they got less atherosclerosis. So it was finally my basic science interest got tied into my clinical interest. And then it was very interesting. We noticed that, we'd always talked about the macrophage, and this goes back the lipid-laden macrophage, foamy macrophages in the arterial wall, but we looked in these mice and they have foamy monocytes. So you have lipid in the monocytes, and with these mice actually people do, it's tendinous xanthomas, the mice on their skin, when they rub up against the cages, areas of trauma, they get these xanthomas. And then it turns out that those monocytes, and then they're activated, they express C11C, the knockout had less atherosclerosis, CC was missing. And so there's a whole model, it turns out, in data later on that came out that in humans with FH, what you see is increased foamy monocytes, just like you do in the mice. They have increased C11C expression, and it turns out the PCSK9 inhibitors, which dramatically lower LDL, reduce the number of foamy monocytes and also reduce C11C expression. So although PCSK9 inhibitors have no impact on hsCRP, they do have an impact on what's happening in the monocytes in these people with severe hyperlipidemia. So inflammation was an area of interest, and I spent years on that, and I got involved as a member of the steering committee for a study studying an agent called canakinumab. It was anti-IL-1 beta. And it was really this was an example of when you're involved from the start. This was going to be canakinumab at 150 milligrams versus placebo. And so then basically the company said, well, maybe we could see if a higher dose was more effective. And the FDA said, well, if you want to look at that, want to see if a lower dose is more effective. And the next thing you know, you have 3 doses against the placebo. So this is how these trials end up happening. It's back and forth. And it was also, uh, this was Paul Ritker and Peter Libby. And so they were like, okay, listen, we're going to meet with the people at Novartis. You guys have got to help us sell this study to them, and so to explain how important it is for them to do it. So they talked them into it, and we all tried to help. But it was a positive trial. They reduced events by 15%. Although if you look at the p-value here, it looks impressive until you read the paper carefully. And because of the multiple groups, it just barely made significance. Devil's in the detail here. HSCRP went down, no change in LDL. There was an increase in fatal infections. That's what you would predict with an anti-inflammatory approach. However, there was a reduction in fatal malignancies. And that was the good news for the study. There was a reduction in cancer mortality. So it was good news for the study. However, in a way, for cardiovascular, it was a bad news because Novartis decided, gee, there's more promise of this in cancer than there is with cardiovascular. So basically, they did not pursue approval. If they tried to get this really, really generous label, they didn't get it. And so now it's being pursued in cancer. But it shows the proof of concept that, yes, inflammation is important. And clinically, there are approaches that can reduce events, although this one does have an adverse effect can be severe, but maybe something else could be better. Well, we were interested. I was always trying to do some clinical projects when I was in the lab, and so we looked at adhesion molecules. Since I was studying adhesion molecules in people with hyperlipidemia, saw that they were increased in people who had high triglycerides. We started working on therapies with omega-3 fatty acids back in the 90s, and we saw that treatment with an omega-3 fatty acid reduced the levels of triglycerides, and it reduced the level of adhesion molecules. And this was work with Henry Pownall and Tony Gatto. And for years, we focused on LDL, and then we also focused on HDL. These were our 2 major areas of focus. And we didn't do that much with triglycerides, although the Patch brothers at Methodist in Baylor always said they were important, and they actually felt they were in the causal pathway. The genetics have basically shown that if you look at the genetic variants involving LDL, they always predict cardiovascular events. The genetic invariants involving triglycerides also predict cardiovascular events. The ones that involve only HDL are not associated with cardiovascular events. Now, there is a caveat. The genetic variants that affect triglycerides, most of these also affect HDL. So this is looking at only a subset that does not affect triglycerides, and triglycerides and HDL are very closely intertwined in terms of the physiology with triglycerides and HDL. So basically, but this now shifted the focus back towards triglycerides. And in fact, all of the genes important in catabolism of triglyceride-rich lipoproteins, these have each been shown to be related to atherosclerotic cardiovascular disease, and now there are clinical trial programs targeting all of them, essentially. So, going back to those foamy monocytes, it turns out if you have a high-fat meal, what we see is that, once again, the people who get very high triglycerides have foamy monocytes in the postprandial state. So a fatty meal for someone with metabolic syndrome actually leads to some activation of these foamy monocytes. They have increased adhesion to VCAM1, and that would mean they'd stick in the arterial wall and potentially, go into the intima. So once again, this was back about a decade ago. A small company came and said, we want to study an omega-3 because there had been a Japanese trial called the JELA study with EPA. And they said, we think EPA would be very beneficial, that it's not going to raise LDL. So we did they came, would you be the PI of a study? And we did a trial called the ANCHOR study. It showed it reduced triglycerides moderately, and there was no adverse effect on LDL. And so then they said, well, we're going to do an outcome study. And I was like, okay. pretty small company to do an outcomes trial, and no one had ever done an outcomes trial in the area of triglycerides. There had been one planned by GSK, and they backed off at the last second. And so they did it, and lo and behold, you know, if you don't try, you'll never know. And they did this trial, and it was a member of the steering committee. Deepak Bhatt did a great job leading this study, and it showed a benefit. It was the first trial that recruited high-risk individuals based upon high triglycerides. And it's embarrassing. I was looking back in my CV. I was at an NIH workshop on precision medicine in 2006. They were talking about omics. And I said, well, we're a long ways from personalized therapy. We've been measuring triglycerides forever. We don't even know what to do with high triglycerides. That was in 2006. So this is still 2019. We have our first high triglyceride study. We've got more in the pipeline, but getting the evidence is way behind getting the information about these markers in terms of what to do with people. So that's a real challenge for precision medicine for it, because it takes a lot of work and time for these trials. So they were on statins. The LDL had to be under 100. The median triglyceride in here was about 216 with it. And basically, triglycerides were reduced. They went down 20%. Non-HDL went down about 13% for it. There was a very small impact on ApoB and LDL. And there was a slight increase in LDL in the placebo group, which was using a paraffin oil. There was a reduction in events by 25% with it, with very good NNT in this trial. And basically, this was also, if we looked at the cumulative in terms of second events, it was even more impressive. That was published in JACC a couple months ago. So basically, there was a reduction in death, heart attacks, strokes. There was, which was interesting, Miguel, he had to leave, slight increase in AFib. And part of the reason that's interesting is that Craig Pratt had done a previous study with EPA DHA, where he'd led the steering committee, and if the trial failed, and then that study was that it failed, but not only was there no reduction, there was in the wrong direction, also towards an increase in atrial fibrillation. So it was a small, and it was, there weren't any strokes or anything, but still it's something that we don't understand fully. So if we look at where we've come from, let's going back with it, we've made a lot of progress on what we know in the last, since I was at Parkland. Certainly we know a lot more about LDL with it, and we finally have some diabetes therapies that work. We have much better antiplatelet drugs, and also anticoagulants, that we now have some data in terms of benefit here. So I've been fortunate to be involved with two of these areas where we've had really some of the novel information, which is this issue of the omega-3s and also canakinumab. So they kind of, both because of my interest in inflammation and lipoproteins, got into those. So I'm going to finish up with this research. It's a journey, not a destination. We keep evolving. I'm looked back here where we were, and for the people, I know some fellows just started this week. So our Baylor fellows and Methodist fellows are getting started this week, and I think back, so what's it going to be 25 years from now? A lot of exciting things going on in the area of imaging, biomarkers, genetics with it, and finally, been lots of guides and companions on this journey here over the years with it. I see Biba over here with Tony Gatto and the group that we're all here, lots of postdocs, and most of all, my family who were put up with me when I was working crazy hours as a young person trying to do basic research and see patients, then added on to that biomarkers and clinical trials with it. Thank you very much.
Great. Thank you, Christy. That was a really phenomenal presentation. The floor is open now. Any questions for Dr. Ballantyne? I'll let Dr. Zogby start it off.
Christy, pleasure having you. I know your plane was not delayed this morning. So. A really nice overview of where we were and where hopefully we're going in this journey. From a practical point of view, currently, do you do any biomarkers beyond the traditional things, particularly, let's say, CRP? Where is it now, knowing the role of inflammation? Are we targeting it one way or another from patient practice nowadays? NT-proBNP, we have some data, at least in the heart failure population, that is similar actually to an echocardiogram. If you have hypertrophy, if you have a left atrial enlargement, if you have Doppler. So for those people who get these other testing, do you need it? Or even without that, just looking at a 30,000 foot level, do we need them at this stage of the game?
So I think HSCRP has been something that I'll get in a primary prevention where I'm not sure about risk sometimes. It's maybe kind of a coin toss. They talk about risk enhancers is what they've used in the new guidelines. So if they have a high PCE, you don't need it. But, these people of 6%, particularly if someone's overweight, there's concerns about that might be motivational for a lifestyle modification. Secondary prevention, other than lifestyle modification, if you're using, we're not going to really do that much with it. NT-proBNP, I have begun to get more frequently in my patients, particularly with hypertension, in terms of that. And the other one that comes up is I think there's the other issue, Bill, is there needs to be almost a campaign, is that a lot of the echo findings which come back enlarged, and I would say the classic one is left atrial enlargement. Unfortunately, that does not ring the alarm bells for, boy, I better treat hypertension more aggressively. I've never seen that link put together so that when the report comes back, consider being aggressive with blood pressure. But it is we just looked at this in the ERIC study for, AFib. That's the biggest predictor for AFib. It's a left atrial size, but it also was the biggest predictor for incident heart failure, too. You have echoes in ERIC? There are echoes from visit 5 and now visit 7. So we've got 2 echoes and we have the biomarkers, but this whole issue of left atrial enlargement, most of us who got trained in the past, we just kind of blew that off. It's not an important finding. And then sometimes, so early, grade 1 diastolic dysfunction, so everybody's got it. But, it hasn't been this thing for, I think NT-proBNP, we're going to get the data, we're going to do a study from SPRINT, where we're going to measure NT-proBNP, troponin T and I baseline in that 1 year. So that would be very important to have more evidence that you could target that, and does the drop help tell you if you had a benefit? So I think that's the marker that needs a little more trial evidence from M Therapeutics. But the other one would be is that I think you get that data from the echo. We saw that the 2 were actually additive from it. But, I don't know that people act upon it. These subtle echo findings, which are in fact very powerful diagnostics for heart failure and AFib.
Great. So just a quick question. You touched on this a little bit, but with regard to diabetes and heart disease, just in my career, it seems like we used to think, yes, treating diabetes improves cardiovascular. And then there was studies, last decade that really called that into question. And then now again, you've got these SGLT2 inhibitors. Do we know the mechanism? Do we know how it is?
So we don't know the mechanism for that, and it looks like you're getting some different SGLT2 inhibitors seem to be doing very well for heart failure, and some of the GLP-1s seem to be a little bit better in terms of ASCVD. Now, some of that is that some of these things you're losing now a fair amount of weight too with it, but there's these modest changes in multiple factors. I think that the interesting thing is going to be is seemed like a crazy idea that spilling glucose in urine would help, but there's some metabolic changes in regards to fatty acid metabolism, which could be really important for the heart. I know Dale's looking at that. I think you were looking at it with Dale, but I think it's a very exciting area for research.
Great. Any other questions for Dr. Ballantyne? One over there.
I have more of a personal question in regards to earlier you had mentioned that the research being conducted seems promising. And in your career, in times where the research wasn't as promising, how did you keep going? And what's been like a motivational factor for you?
Well, I think this is it's a very challenging thing in terms of research because we had a thing called the Buer Fellowship at Baylor, and so I was one of the first Buer Fellows and did a year. I was working in the lab, and I went on the faculty the next year. It was a protected year of research, and my salary said, well, your salary is going to be $45,000. I'm like, wait a second, that's the same as my fellow salary, but I'm on the faculty. And said, well, you have protected time for research. Now, my wife's a CPA, and she's also Lebanese, so that's the other thing. So she understands money. She says, well, she said, you've been telling me that research is important. She said, but in the business world, if something's important, you pay them. So why are they paying you the same as a fellow and less than a family practitioner? So had a hard time answering that question. And so it's very challenging. You have to have I'd say the one thing is you have to have a passion for it. You've got to love it. And the other thing ends up, and this is, I will say, one thing that comes up, which was a great lesson learned from Huda, is you have to be extremely focused. And you need to set goals that are achievable. And it's the same thing. If you want to climb a mountain, where do you look? You look up you look towards the peaks once in a while, but you're looking on the ground each step, and you have these. You're going to go to here, and then you're going to go over to here, and you're going to go to there, and eventually you get to the top. But you need to have a path where you'll have some milestones that are achievable, that you can also publish, that will help you get grants, and you have to have good strategy, and you have to be very focused on getting results. But you have to really work efficiently, and you have to work hard. So I wish there was something easier than that. It's good to you need to find good mentors, and then you need to be able to bounce ideas off of other people to help you in terms of your grants and your manuscripts. And you really have to stick to timelines. You can't procrastinate. If you procrastinate and don't meet your timelines, you're going to get into trouble.
Great. I think that's a very inspirational way to end off the year. So thank you again, Christy. And so this concludes our grand rounds for this academic year. We look forward to seeing everybody back next year.